Okay, so we're on class 16 and we want to continue getting through these issues for healthcare. So we're up to page 53 of the articles. This one's on evidence-based medicine, which I think is a really key issue. And we're at the opposite area where we're actually not using evidence to make decisions about medicine. Instead, inefficiency is encouraged. So about half of all clinical trials are never published. Companies are allowed to run many tests and publish only the ones that with the results they like. Here they're talking about pharmaceuticals and drug tests. Unsurprisingly, negative results are far less likely to appear in public. It's almost a just trial and error until you get a potential false positive or false negative, either one, and you market that. Some patients may have died because data about potentially dangerous side effects were not published. Volunteers in clinical trials may have suffered harm for no reason. So you can see the system is not set up to put the patient first. That's why I keep emphasizing this outcome-based medicine that we'll talk about with Michael Porter. Here's another example. Americans are furious about costs of medicines. This one company raised the price of EpiPen, an injectable medicine that fends off deadly allergic reactions. It raised it to $600 from $100. Both Hillary Clinton and Donald Trump, this is before the election, were proposing measures to tighten controls on drugs. Donald Trump has continued to harp on that issue, but you notice that he doesn't get too far, mainly because Congress gets a lot of money from this industry. It's very hard to change this industry because they keep Congress essentially at bay. The pharma firms, this is a worrying prospect for them. They have the federal government stepping in. To date, the government has done little to lower or cap spending on medicines. Across Europe, governments control prices in one way or the other, but American drug firms can set whatever official price they like. Their single biggest customer obviously is Medicare, which spent $112 billion on medicine in 2014. The way it operates rewards doctors for selling costly intravenous drugs. And it is illegal for Medicare to negotiate with drug companies. As a result, we spend 44% more than Canada. I should have put on that one, I just put fraud and waste. But again, it's inefficiency is encouraged. When you can charge whatever you want to, boy, and then we'll talk some about the kickbacks to doctors as well that encourage them to prescribe these drugs. The most egregious case remains Turing. A small company bought an old HIV drug with an expired patent and boosted its price 5,000%. You may have seen that in the news not too long ago. In the field of patented medicines, the industry points to the billions of dollars that are required to develop new treatments. Many question whether drug firms' profit margins, which are greatly exceed those of other industries, especially in the case of biotechs, need to be as high as they are. Private insurers, now obviously pharma, they argue developing a new drug can cost billions of dollars. It can take many years. We should get and it may not even work after all that time and money. So we should get a big return, because in order to build things like COVID-19 vaccines, we've got to do a lot of research, a lot of costs. What they don't talk about is how much money they get from the federal government to subsidize much of their research. We'll see that in a later book and some later articles, definitely. So private insurers and pharmacy benefit managers such as Express Scripts are old hands at resisting high drug prices. They use copay schemes and other incentives to push patients toward cheaper medicines. They also refuse to pay for some new drugs when there is a reasonable alternative. So there are some on the other side. I tried to sign up for Express Scripts, but there's something wrong with their website or something. I never could get it to work. But there are some in the business. We're going to talk about some pretty exciting ones here not too far from now. So fraud, again, in the system. And we obviously have an opioid issue in the United States. Many of these are being prescribed by doctors for pain, and then people get addicted. They found that opioid manufacturers are paying physicians huge sums of money, and the more opioids the doctors prescribe, the more money they make. Opioid manufacturers paid hundreds of doctors across the country six-figure sums for speaking, consulting, and other services. Thousands of other doctors were paid over $25,000 during that time. Physicians who prescribed particularly large amounts of drugs got paid more. On average, doctors whose opiate prescription volume ranked among the top 5% nationally received twice as much money from the opioid manufacturers compared with doctors whose prescribed volume was in the median. Doctors in the top 1% received an average 4 times as much money as a typical doctor. Doctors in the top tenth of 1% received 9 times more money. Every decision, every recommendation a physician makes should be in the best interest of their patient, obviously, and not a combination of the patient's interest and the financial interest of the doctor. So I'm not real sure where I put that one. Obviously, fraud could be part of this. So I didn't. Yeah, I'm calling these fraud. I think inefficiency being encouraged obviously is there. If you're overprescribing drugs, that's inefficient. So I don't, I'm not saying all of these go obviously in one particular category, but they're somewhat intertwined. From August 2013 through December 2016, this doctor was paid nearly $1.5 million by companies that made these opioids, according to the Federal Open Payments Database. Most of the payments were fees for speaking, training, and education. One of his patients says she remembers Simon bragging about how many drug companies were flying him across the country to give lectures to other doctors. He said he was going to Miami and they were going to give him a convertible and he was going to stay in the best hotel and eat the best Cuban food he'd ever had. Now she became addicted to opioids, so she's filing a lawsuit. But I think you can put that under fraud. Bad incentives at least. Remember, the word incentive is a big part of this paper. And you're seeing the incentives here are, we could put this definitely under focus on treatment over prevention because doctors are making a lot of money by prescribing and they're not making a lot of money by actually making people well. So what is the solution? So here's one solution, which is to actually pay people or incentivize people for healthy living so they don't have to buy pills, they don't have to have surgeries. So reward healthy behavior. Safeway was in the news on this. You might check and see how this is going. This is a very old article. I have not seen anything more recently. But the one who wrote this article, I don't know if it's the CEO of the firm or one of the high-ranking officers, he said, "We have kept our per capita healthcare costs flat, while most American companies saw a 38% increase. The first is that 70% of all healthcare costs are the direct results of behavior. So we can cut a lot of our healthcare costs if we can just get people to eat right and exercise. The second insight, which is well understood by providers of healthcare, is that 74% of all costs are combined of 4 chronic conditions: heart disease, cancer, diabetes, and obesity. And obviously those obesity is related with the other 3. Furthermore, 80% of heart disease and diabetes are preventable, 60% of cancers are preventable, and obviously obesity is preventable. So American lifestyles is an issue. So one of the solutions we say is how to incentivize people for healthier living. So I've had this discussion. I wish we were in class. It's a really interesting discussion. We're talking incentives. How do you incentivize people to live healthy lives? And I start off with the contention that you only get one shot at this life. You only get one body to go through this world. It seems like the incentive is already pretty great, that we should take care of our bodies, but we don't. So we're adding monetary incentives on top of something that should already be more than adequately incentivized. This is our body, our one shot through this life. But it seems to work. You would think people would take care of themselves just so they could live a nice, long, healthy life. That doesn't seem to be enough. Giving them short-term monetary compensation does seem to actually change behavior. The question is how sustainable it is. So this Safeway article implies that it's actually helped them keep their healthcare costs from rising a lot the way it has been rising with other companies. So you want to change bad behavior like speeding, tickets for failure to follow rules, frequency of accidents are considered when establishing insurance premiums. So if you have that same incentive with drivers, why not do the same thing with with tobacco use, healthy weight, blood pressure, cholesterol levels. Those things the employees can actually have an impact on through exercise and diet. What if we paid them more if they did that? So how do they do it? So here, you may think this sounds a little too big brother. If you think about your solution for this, how you would have to actually set this up so that it would not be so intrusive. But the employees are tested on these 4 measures: tobacco use, weight, blood pressure, and cholesterol. That gives them a base level. Or they go against a base level. If they pass all 4 tests, the annual premiums are reduced $780 for an individual and $1,560 for families. So they fail all tests, they can be tested again in 12 months. If they pass or have made appropriate progress on something, the company provides a refund equal to the premium difference. So they're trying to incentivize them. So think about that, $1,500 for a family or $700 for individuals. So we're talking, for an individual, maybe $60 a month. $60 a month, you would think the fact that it's their body and their life, that would be more than enough. Why would another $60 be enough to get people to change? But you can see there's a psychology here going on. So it's American lifestyles is the issue, and can we find incentives to get people to be healthier? So one thing I want you thinking about, it's not in the articles directly, we'll see it in some of the articles, but what if you told someone, if you exercise, you go to the gym, you prove that you exercise, we'll pay for your gym membership. If your weight comes down, we'll pay for your we'll even subsidize you to buy healthier food. And at the very end, we'll pay $2,000 or $3,000 for you to help you exercise, much more than what they're saying in this article. At the very end, we'll save $5,000 in healthcare costs. You'll be ahead, we'll be ahead, and you'll be healthier. Are the ways to work this so we incentivize? Remember, one of the early articles said the healthcare system focuses on what healthcare gets paid for, which is treatments, it's medications, it's surgeries. Healthcare doesn't make money when people go to the gym. The healthcare system doesn't make money when people eat correctly. Can we find a way, and we're going to get to this Michael Porter outcome-based medicine, where compensation is based on how healthy the population is and not based on how much treatment doctors do? Can you think of a system, and I've seen some students in prior classes with some really interesting ideas. How can you incentivize people to live healthy? So SAFE would like to do this more. They say we are constrained by current laws from increasing these incentives. We reward plan members $312 per year for not using tobacco, yet the annual cost for insuring tobacco is $1,400. So they'd like to be able to give them the full $1,400 or at least $1,200. Reform legislation needs to raise the federal limits so that incentives can better match the true incremental benefit of not engaging in unhealthy behaviors. Now remember, healthcare is heavily tax subsidized. If you don't take that tax subsidy and also bring it to these, people are given $1,400 for not smoking. The company saves $1,400 but gives $1,400 to the employee, but the employee has to pay tax on that $1,400, then they're going to be behind by the tax on that, because they're losing the higher health care, but they're having to give up smoking. So again, it's American lifestyles and it's incentives for healthier living. So let's look at it. So here's a big part, I think, of the paper, which I think is really, really interesting. It's which has better efficacy. Efficacy is, we're looking at the cost versus the output. Which has more efficacy, exercise or pills? And you probably already know the answer to that, but let's just look at it. Exercise may be just as good as pills for some conditions. It says for patients and doctors, pills are easier. So it's easier to get someone to take a pill than it is to get them to exercise. And remember that doctors don't get paid when people exercise. There's no difference in efficacy between exercise and drug interventions. When it comes to heart disease and diabetes, they perform the same terms in reducing your chance of death. With respect to stroke, exercise perform better than some drugs. With respect to heart failure, some drugs perform better than exercise. But you think about it, exercise does have some side effects. You can hurt your knee, or you can get injured. It could even cause someone to have a cardiac arrest, if they don't exercise correctly, if they overdo it. It has some side effects, but its side effects tend to be much more manageable, much more predictable than the side effects of drugs. Exercise interventions, which are often far less intensive than you might think, can significantly reduce your chance of dying. Exercise is usually cheap, if not free. We're talking walking 30 minutes a day. I ride my bike 3 hours a day, so I'm a little overkill. But where I ride, it's the hilliest part of Texas. It's the second steepest hill. And the people out there walk for 30 minutes. When they walk 30 minutes, they're getting a really good workout because those hills are steep. So you don't have to go quite that extreme, but 30 minutes of walking a day is great. I know there's a good friend of mine. She started walking every day. I think she got 10 days in a row. And I was like, keep it going, keep it going. And then they just stopped. It got too hot and all that, and they just couldn't keep it going. But how do you get people not only to start, but to keep doing it? So exercise has few side effects, but it does have side effects. It's not a free. So again, American lifestyles and healthy living. How do you combat the bad lifestyles and get people to start living healthy? Taking medication can be simpler. A doctor can prescribe it immediately. We're not talking about someone who have to walk 30 minutes a day for years. One student in my class said his grandmother had diabetes, and he got her walking 30 minutes a day. And her next doctor's appointment, there was no sign of the diabetes. She was perfectly fine. Completely cured her just to get out and exercise because she had not been exercising in her life, and her body just immediately reacted to that. It was pretty amazing. So that's part of the problem with our medical system. Every time a doctor writes a prescription, he or she is probably earning some money. The pharmacy that dispenses the med makes money. The pharmaceutical company makes money. The healthcare system encourages this practice. Insurance pays for it. It's easy. Whereas exercise, someone's got to get up, they got to go out and work, they may have to buy new shoes. But the same healthcare system is not at all equipped to deal with lifestyle change. No one makes any money if you are more active. No one would ever think to write a prescription for gym membership, but why not? Why can't health insurance companies pay for gym membership? Why can't health insurance companies pay people to stop smoking? Which could easily cost less than the medications, with the same potential outcomes. It is highly unlikely that a similar number of people will be encouraged to exercise. One is considered doing something by the healthcare system, whereas exercise is not, you go out and exercise, the healthcare system says, well, we didn't do anything. One is paid for by the healthcare system, the other is not. But as evidence amasses that lifestyle interventions are as beneficial as medical ones, it may be time to rethink how the system works. So we're going to give it to Michael Porter. The goal is, how do you make people healthier? Better water systems, better exercise opportunities, more bike paths, more walking paths. I think a lot of more people would ride their bikes to work if they had a safe bike path and they had a shower when you got to work to shower and change. I would ride my bike to UTSA if I just had a place where I could shower and change. It would be great. But, so it's simple things that get people to exercise. And there's plenty of money. Remember that $1 million, I forget the number, $1.77 million the second article talked about. There's plenty of money being spent on this. Could we spend it more wisely? So why are we so focused on treatment over prevention? How do we incentivize people to do the cheaper thing, which is probably even more helpful? All right, so now we're going to shift gears. Page 73. This is an issue I find really fascinating. Maybe because I'm getting up there in age. You guys are so young, you probably don't think about this at all, but you have grandparents probably going through this. And it's this baby boomer issue, which you covered in paper 1 on that third and fourth article. So this baby boomer issue of how do we handle people at the end of their lives. So for most people in the developed world, conversations about end of life type of issues, they just never take place. Young people were marked in passing. They'd rather be dead than go into a nursing home, and a lot of people feel that way. In fact, I just heard a guy today on in a podcast saying that exact same thing. The closer that end is, the less it is talked about. The result is that hard choices are made without an understanding of their consequences. More and more people spend their last hours exactly like they did not want to, hooked up to machines. And the video I'm going to send to y'all in the weekly email, you will definitely, I think, see that one story. It's a really painful story to watch. They find themselves admitted to hospitals for what they think is treatment that can fix them, only to be stuck there until they die. And most people don't want to die in the hospital. This guy, he has a book. I don't know how to say his name. Gawande, I think. I forget what I think it's called. Being Mortal. I I don't know if you would read it at your age, but your parents should probably read it. As far as them dealing with their parents, dealing with your grandparents. It's a really fascinating book. It's very well written. It's a very sympathizing, kind of tender book in the way he wrote it, because he's writing it about his dad. So he's thought a lot about this. He's a doctor who's thought a lot about this end of life care. And he says, like, he explains why modern medicine has turned end of life into something horrible. A nursing home that puts safety before anything else. Our most cruel failure is how we treat the sick and the aged. It is a failure to recognize that they have priorities beyond merely being safe and living longer. I mean, good examples are, 90-something-year-old man, he wants to smoke a cigar. You say, oh, that's terrible for your health. You can't do that. It's like, my word, let him, he made it this far. Or he wants to have a dog. A 90-year-old woman wants to have a dog, and you say, oh, you can't do that. You might trip over them. They might get on your feet. And he's saying, you know what? It's their life. Let them risk. They might die earlier, but it's better than where they are. He actually says, I can't remember if it's in this article, but in his book, he talks about how a lot of people in their 90s are living less free lives than hardened criminals, murderers in our prison system. They're so cooped up, they're so locked up because everybody's worried they're going to slip and fall. They're living the life of a prisoner with even less, prisoners at least, that get to get out of their beds and go exercise every once in a while. And so many people fear that a doctor who does not try everything possible has abandoned his patients, and they will die early as a result. Surprisingly, the try everything approach appears to not even offer longer lives. Now, this is pretty amazing stuff here, these next few statistics. Multiple studies have shown that patients entering hospice care, which usually means abandoning attempts to cure, live at least as long as those receiving traditional care. Think about that. Hospice care, where you're with your family, you're in a very pleasant environment, you live just as long, if not longer, some of these studies say longer, than those hooked up in a hospital bed where your family can't visit you except for certain hours, and it's limited, and it's very sterile, very noisy, very bright. A startling study found that patients with advanced lung cancer who saw specialists in palliative care, as well as receiving the use of oncology treatment, stopped chemotherapy sooner, entered a hospice earlier, suffered less, and lived 25% longer than comparable patients who received only the standard care. So this is the end-of-life care, and do we put any kind of cap on end-of-life care? And by cap, we're going to talk about this. It's a touchy issue. We'll get into it when we talk about the videos. I'm not sure exactly how we'll discuss the video. Probably have an online Zoom. But how would you handle that particular situation that's shown in the video? All right, moving to pages 75, 76 of that collection of articles. Most physicians would forego aggressive treatment that they themselves give to other people. So I think when you talk about capping end-of-life care, it's not that we're letting people die who want to live. We're actually here when physicians themselves who know what's going on, they see it themselves, when they're asked what kind of treatment they want, they're picking a very different treatment than what they're actually giving to their patients. So most physicians would choose a do not resuscitate or no code status for themselves when they are terminally ill, that they tend to pursue aggressive life-prolonging treatment for patients facing the same prognosis. The passage of the Self-Determination Act in 1990, a law designed to give patients more control over determining end-of-life decisions. Advanced directives are the documents that patients can use to indicate end-of-life care, but a big disparity exists between what Americans say they want at end of life and what they actually receive. More than 80% of patients who say they wish to avoid hospitalizations and high-intensity care, their wishes are, 80% say they don't want all that, but often their wishes are overridden. Because of this act, doctors now feel they are less likely to be sued for not providing the most aggressive care if the patient has an advance directive. The law requires hospitals to inform patients about advance directives, but it does not ensure that the directives are followed. At the core of the problem is a biomedical system that rewards doctors for taking action and not for talking to their patients. Again, it's that focus on treatment over prevention or over anything else. Our current system faults is doing, but in any serious illness, there comes a tipping point where the high intensity treatment becomes more of a burden than the disease itself. We don't train doctors to talk or reward them for talking. We train them to do and reward them for doing. The system needs to be changed. So end-of-life care, do we cap end-of-life care? Again, there's so much end-of-life. It's a huge part of this. If you wonder why Medicare, covers, I forget, maybe 20–30% of Americans, but it represents over 70% of the cost. A lot of it does relate to this end-of-life care. Most deaths in rich countries follow years of uneven deterioration. Roughly 2/3 happen in a hospital or nursing home. After a crescendo of desperate treatment, nearly a third of Americans who die after 65 will spend time in intensive care unit in their final 3 months of life. Almost a fifth undergoes surgery in their last month. Now you might say, well, then the surgery killed them, but really the surgery had very little hope of saving them, and even if they had lived through the surgery, their life would have been extremely limited, and they still went through the surgery. There are people in their 90s having prostate surgery, even though it's highly unlikely. Remember, 1 out of 14 chance that it saves your life. 13 out of 14 people, it doesn't save their life, and yet they're having very dangerous surgery in their 90s for something that has a less than 10% chance of saving their life. In that case, they're probably more likely to die from the surgery than been saved by the surgery. Experience more pain, distress, depression than patients who die in hospice. Families are more likely to argue with doctors and each other, to suffer from post-traumatic stress disorder, and to feel prolonged grief. So it doesn't just harm the patient to leave them in the hospital for months hooked up to wires, which means they may actually die earlier than if they went to hospice, but it also affects the family, it affects hospitals. It's a very difficult group to administer health care to. So we got to ask, what is most important? Most important, these medicalized deaths do not seem to be what people want. What do people actually want with their lives? Most people in good health hope that when the time comes, they will die at home. Few, when asked about their hopes for their final days, say that their priority is to live as long as possible. Rather, they want to die free of pain, at peace, and surrounded by their loved ones. Too often, patients receive drastic treatment in spite of their wishes. By default, when doctors do everything possible, as they have been trained to do, without talking through the people's preferences or ensuring that the prognosis is clearly understood. So again, it's end-of-life issues, and so we put a cap. So how do you talk about the cap? So this is a tough issue. Obviously, we saw in the debate during the Clinton administration and during President Obama was this concept of death panels, and I think it was death panels was somewhat exaggerated versus what the law actually said, but that is the concern. There's definitely a moral issue here of, what do you force people to do, or what do you encourage people to do? It comes down to incentives versus what you actually mandate. I do want you to think, when you're watching the video, and there's this woman who is brain dead. She's in a hospital bed, hooked up to a lot of things, not responsive at all, doesn't have any awareness of what's going on around her. And the doctors say, there's nothing that we can do. She's not there. Do you want us to keep her on life support? And her son says, yes, do whatever you can to keep her alive. And I forget the dollar amount. It's a few $1,000,000 that it costs to keep this lady alive for 3 months, and then she finally died. She was in a coma the entire time, never came back to consciousness. And $3 million. So you say, well, he has the right to say that, but then the question comes down to who pays that $3 million. Does he have the right to force U.S. taxpayers through Medicare to pay for that? So these are tough questions. I'm not saying they're easy answers, but I do want to see your opinion on these really tough questions where we're spending a lot of money at the end of life on a 1 in a million chance that you might extend the life a few months. This newspaper has called, this is, I think, well, I can't remember which newspaper this is. I'd have to go back and see. I can't remember what this is. It might be The Economist, probably, even though it's not a newspaper. This newspaper has called for legislation of doctor-assisted dying so that mentally fit, terminally ill patients can be helped to end their lives if they wish. Now, obviously, there's strong moral arguments against that I've definitely have heard. So I'm not trying to sway you one way or the other, because one of the issues, I said you can implement whatever solution you want as if you're a king. You don't have to worry about the political ramifications. This is one where you may want to think about that a little bit. Do you really want to dictate that, hey, if you've got this disease, healthcare can't treat you? That's what they do in the UK, and it's pretty shocking in the UK to say we will not treat you, even though there's a chance this might save you. Our system doesn't pay for this, and they won't even let you spend your own money and go to another country to get the treatment. It's pretty amazing if you've seen some of these stories recently in the press. So more palliative care is needed. This neglected branch of medicine deals with relief of pain and other symptoms such as breathlessness, as well as counseling for the terminally ill. It encourages more early conversations and reduces suffering. Much care for the chronically ill needs to move out of hospitals. That would mean some healthcare funding being diverted to social support. So again, this can be part of your solution. Um, so families have the right to demand on certain kind of care, but the doctors say it's hopeless, they're brain dead, then do you change the system so that more of the cost has to go to the family, so that they're not pushing everything off to the taxpayers? And how would you set up a program like that? That would mean some healthcare funding needs to be diverted. Financial incentives for doctors and hospitals needs to change. They are typically paid to do things. We've seen that before, rather than to prevent. And not to prevent disease or make patients comfortable. Cost is not an obstacle, since informed, engaged patients will likely to want pointless, unlikely to want pointless procedures. Politicians are scared to bring up end-of-life care because of these death panel arguments. So tough issue. Another article on the dying. This was a big issue a few years ago because Oregon passed a right to die law. I think California has one as well. You might want to do a little more research on those particular, the right to die. A few states that have passed it. I think Switzerland has one. And see how they actually handle it. It might be an interesting extra little research to do. This is a really fascinating area. The paradox of modern medicine is that people are living longer and yet doing so with more disease. Death is rarely either quick or painless. People tend to have goals that matter more than eking out every last second, but too few are asked what matters. So many die alone, confused, and in pain because they're sitting in a hospital or nursing home. And think about today, we have people sitting in nursing homes with no interaction because of COVID-19. It really is a sad state for a lot of people that our society maybe could handle much better. Reformers are overhauling how end-of-life care is delivered and improving communication between doctors and patients. The changes mean that patients will experience less pain and suffering, have more control of their lives right up to the end. Kind of what I was talking about in that Being Mortal book was talking about. Let people make decisions that may actually end their life earlier, may actually cause them to fall and break something, but it's their life. Let them make those decisions. In Britain, only a fifth of deaths are sudden. For example, a car crash. Another fifth follow a swift decline, as with some cancer. But 3/5 come after years of relapse and recovery. They involve a slow, progressive deterioration of function. People in rich countries can spend 8 to 10 years seriously ill at the end of life. A century ago, most deaths were at home. Now, according to a survey of 45 rich countries, fewer than a third occur at home. Today, poor people in rich countries are more likely than their better off compatriots to die in the hospital. So there is some issue here of inequitable treatment between different groups of people. Many deaths are preceded by a surge in treatment that's often pointless. An eighth of Americans with terminal cancer receive chemotherapy in their final fortnight, despite it offering no benefits such as at such a late stage. Nearly a third of elderly Americans undergo surgery during their final year. 8% do so in their last week. The way healthcare is funded encourages overtreatment. Hospitals are paid for doing things. We've seen that multiple times here. Incentives. The huge gap between what people want and what they get still remains. In all 4 countries, the majority of people said they hope to die at home. Only small share said that extending life as long as possible is more important than dying without pain, discomfort, or stress. You might think for yourself, or you might even, if you want to have a tough conversation, during Thanksgiving where you're at home, maybe not around your grandparents, but with your parents, how are y'all going to handle when our grandparents get into their 90s? And how do you want us to handle when you get into your 90s? Have these kind of conversations. That's what I liked about that book, Being Mortal. He had these conversations with his father, and it's a really poignant book of him really trying to understand what do people want at that stage in their life. Dying people's wishes are often unknown or ignored. Between 12 to 24% of those who had lost someone close to them said that the patient's wishes had not been carried out. Between 25 and 38% said that friends or family had experienced needless pain. Doctors commonly overestimate how long the terminally ill will live. They erred on the side of optimism, so the doctors are making it worse, saying people have 3 months to live when they really only have weeks. When patients with advanced cancer are given palliative care alongside standard treatment, the group receiving palliative care had a lower rates of depression, and all but one study, patients in those groups were less likely to report pain. Remarkably, in 3 trials, the patients receiving palliative care lived longer, even though the quantity of conventional treatment they received was lower. It's just, to me, it's just so amazing. We're actually ending people's lives earlier because we're so over-treating them with surgeries and other things. We're actually causing them to die faster, where they could have died without pain or less painful at home around loved ones. Those receiving palliative care spend less time in hospital, so may contract fewer infections. That's another reason. A hospital is a dangerous place to go. But some researchers think that the explanation is psychological, that through counseling they reduce depression, which is linked to earlier death. The way healthcare providers are funded often sidelines palliative care. So we're not really incentivized to do what the studies say are really the best for the patient. Pretty amazing stuff. All right, so let's switch gears to another topic that I find really amazing. Some of these articles are a little old, but this hasn't changed that much. There has been a little work on this. Some states have changed laws to prevent this from happening, so it's probably not as bad as it was 5 years ago, but it's still there. And health insurance is managed state by state, so some states are probably better than others. So studies are limited, but have generally concluded after 2 years, patients who have surgery for disc problems do no better than those treated with painkillers in physical therapy, although the pain, which can be debilitating, resolves far more rapidly with surgery. So here we have surgery versus physical therapy. After 5 years, they have the exact outcomes. Surgery is far more expensive, exposes the patient to potential infections and other complications, but it resolves the pain much faster. So do you give them, you put them through therapy and they have more pain, but you treat the pain, or do you give them surgery so the pain goes away much faster? They have to go through the rehab after the surgery, but 5 years later, they're in the exact same spot. Some strategies use surgeons, including billing large amounts for a second surgeon in the room. So we're kind of switching gears. That first sentence really is not related to this article, but I think it's really fascinating. We're going to talk about it a little bit more, especially when we watch the video, that when A, B, and C have the same outcomes, but A is the most expensive and C is the least expensive, but the medical system pays for A because hospitals need to cover their capital expenditures. That's a big issue. The next issue, though, here is this surprise billing. Some strategies, they use billing for large amounts for a second surgeon in the room who's not under the plan. He prepped for the operating room on the morning of his surgery. A technician asked him to sign a financial consent form, noting that the company did not accept Blue Cross Blue Shield plans, so he would be required to pay the bill himself. So he's about to go into surgery. Think about this poor guy. He's about to go in surgery and he's being asked to sign something that says, you will pay whatever we charge you. And you will be unconscious when we're running up your bill, and you will have no control over what we do. The person in scrubs who walked a patient to a bathroom for their first time after his hip surgery may turn out to be a physical therapist billing $400. Isn't this amazing stuff? It's a complex system, no transparency. Charges involving the delivery of the device that helped him put on his socks, which he never used. So that was $679. He was irate about charges from a group of hospital-based primary care physicians from inpatient medical associates who visited him briefly once a day and billed him close to $1,000 in out-of-network costs. You can look at this bill. Look at this operating room other, $7,600. Other is the biggest thing on this list. There's been a mushrooming industry mandatory consultants for services that neither doctors nor patients want. So what other business, you're walking into the car repair shop and they ask you to sign a finance responsibility bill. They say, we'll do whatever we want to do to your car and you'll pay whatever. We need you to sign that here. Just absolute insanity. In America, the world's biggest healthcare market, firms that offer health insurance are making employees pay a bigger share, pushing them to search for guidance online. The most sophisticated sites are attracting more users by including reviews and other features. The differences can be startling. The cost of a brain scan in Philadelphia ranges from $264 to $3,271. Wouldn't you like to know the differences in quality between those? If the 264 is just as good as the 3271, then wouldn't you like to know that? But many other governments do not even ask patients for their opinions. German doctors and hospitals have fought efforts to link funding with quality of care. Isn't that amazing? What other industry, again, would ever do that? A research organization said that therefore they're hostile to patient reviews. Doctors' attitude is, hey, we're doctors, we know what we're doing, don't give us a review. I may have a really bad bedside manner, but I may be a better surgeon than anybody else. So you might give me bad reviews just because I wasn't friendly, where really I gave you the best surgery ever. This is a missed opportunity. Patients who hold their doctors accountable make them better and more efficient. That is good news no matter who pays. So yeah, this inconsistent costs between cities, patients seeing the full cost of what they're getting, unlocking consumerism. So that guy that's being dragged in for his surgery and asked to sign a form, if his insurance was paying all of it, he might have said, well, who cares? But since his insurance wasn't covering it, he then said, well, wait a minute, I need to know what you're going to charge me. And he actually said, stop the surgery. I want you to guarantee me what my bill is going to be. I want you to tell me up front what I'm going to pay. So it does change behavior. All right, we're going to get into Michael Porter in more detail. Here's a summary article of it. We'll get into the actual article that he wrote. So he says value should always be defined around the customer. So make note of this article. That gives you a good summary of what we're going to get into more detailed article. So if you need some higher level quotes, because the more detailed article is a little dense, a little bit intense. So this higher level article might give you better quotes to use. Value should always be defined around the customer. In a well-functioning healthcare system, the creation of value for patients to determine the rewards, incentives. Since value depends on results, not inputs, value in healthcare is measured by outcomes achieved, not by volumes of services delivered. And shifting focus from volume to value is a central challenge. I love that quote. I think it's a great way to set up Michael Porter. I don't think it's said quite as well in his article as it said there. The current organizational structure information systems of healthcare delivery make it challenging to measure and deliver value. Now by value, you're going to see he defines value as the outcome, but also the cost. So he's looking at the cost. So he's not just saying, let's make the patients as healthy as possible. It's the health outcomes relative to the input costs to get you there. Providers tend to measure only what they directly control in particular intervention and what is easily measured rather than what matters to the patient. We'll talk about what matters to the patient when we get to Porter, but you'll see it a little bit in some of these articles. Another one, how do you measure healthcare? After removal of a cancerous prostate gland is 76%, but the best clinic is 17%. So which would you rather your parent or whoever is going, your dad, grandfather is going in for surgery, would you want the one that has a 76% error rate, or not error rate, but bad outcomes rate, versus one has a 17% bad outcomes rate? Incontinence, it's 43% and 9%. I forget what that first one was. It might have been impotence, incontinence. Would you rather have a 76% chance or a 17% chance? A 43% chance of incontinence, that would be a really tough way to live your last years of your life, or only a 9% chance? Wouldn't you like to know that information? Wouldn't you like that to be in the healthcare system as far as measuring the outcomes? That's what outcome-based medicine is. Doctors and ministers have long argued that tracking patients after treatment would be too difficult and costly and unfair to providers, particularly unhealthy patients. My argument is, give us information, give us the data. We're not stupid. We'll figure it out. Doctors can advertise themselves. There can be ways to adjust for that, but just give us the data. Some clinics have started to track less obvious variables too, such as how soon after surgery patients get back to work. So there's one of those things where Michael Porter says, let's measure value. One of the measures of value is how quickly can the person get back to a normal life. It's not just that they survived the surgery, but they survived the surgery and they're back at work in 2 weeks, where another guy survived the surgery, he's back at work in 6 months. That's the kind of values outcome we're looking for. By thinking about what matters to the patients, providers can improve care and lower costs at the same time. And that's the other amazing thing, is a lot of these measures that show higher value to the patient, better life outcomes, better health outcomes, are also cheaper. So those pouring money into health-related mobile gadgets and apps believe they can work the miracle of making healthcare both better and cheaper. This is a new article. I just didn't have it highlighted correctly, so you might make a note of that. They invest in a wireless wrist monitor that takes his blood pressure at various times during the day and sends the data wireless to an app, which dispatches the readings. So y'all have seen some of this. Apple is definitely into this, and some others, about wearable devices. By letting doctors and carriers monitor patients remotely and making it simpler to collect vast amounts of data, the mobile health industry, our mHealth, aims to drive down costs for improving results for patients. So Michael Porter. The other thing here I didn't put there, and I kind of just by accident put this article here, is so there's one line here. It says tech reduces costs, improves quality, using information on quality to spur process improvements. There's some other things on this list I didn't hit my arrows. I guess I was getting a little sloppy here at the end. This may alert them to the need for action well before the patient. So we're back to this mobile healthcare, for action well before the patient's condition deteriorates. Given that in America, the average cost of a night hospital stay, we saw that earlier in an article, remember, $4,300 a night. If you can keep patients out of the hospital by catching things earlier, that's a huge saving. Another obvious way to use technology to avert healthcare crisis is checking that the patients are taking their medicines. The goal is to save money while improving health. The average annual cost of, say, treating sufferers with high blood pressure who fail to take their medicines is nearly $4,000 more than those who do take their pills. Now you might say, well, that's their responsibility to take their pills, but I've dealt with people who are having memory problems and really get confused, and these mobile apps, or even other. My brother bought one for my mom, and I probably told you all about this in an earlier one, but just make sure she takes her medications when she should. Not because she didn't want to take it, but just to help her remember. Here's some other technologies that are really helping with the healthcare system. There's a startup. There's 421 young companies that have raised $3 billion. Insurers and hospitals began testing ways to boost efficiency. Man, this is amazing. After all these years, people are now starting to think about how can we do this cheaper without losing the quality of the outcomes. Employers are making their staff pay more for care in cash, which is encouraging them to seek out value. Advances in information technology creates new ways of serving the patients and the hospitals. I probably told you all this earlier, but my doctor visit where I did it online, boy, I don't want to go back to a doctor office ever again unless I just have to. I'd much rather go get the blood test. They send it to the doctor. If there's nothing bad or unusual, there's no reason for me to drive in and meet with a doctor. Just, email me or send me a video or Zoom with me. The law is packed with demands. It caps the proportion of insurers' revenue that may go to profits and administration. They're talking about the Affordable Care Act here. Slashes government payments to hospitals and asks doctors who have profited from heaping treatments on patients to start keeping them well instead. So the Affordable Care Act did have some of this outcome-based medicine in it. I think it was fairly weak and needs to be strengthened quite a bit. Insurers may sell directly to consumers on the new exchanges. Hospitals may apply to become accountable care organizations. So there are attempts to try to address the cost side of this equation. So far, we have not seen a lot of that, but there is some. Definitely process improvements using technology to try to just cut some of the costs out of the system, and getting patients more actively involved, so they pay more out of pocket, so they're more involved. All right, we're almost to the end here. Wow, we're getting close. Treating diabetes, there's an app, so you can see this, gadgets that help people monitor. We've talked about before. The iPhone receives data every 5 minutes from glucose. The combination detector algorithm and pumps reduce the amount of time patients spent with blood sugars by 2/3. So we're not talking small outcomes here, we're talking huge outcomes using tech to address the problem. Here's another, telemedicine. The problems that must be solved at telemedicine's days to come, they include redesigning laws and payment systems to set up for face-to-face care, that are set up for face-to-face care, finding ways to keep patients' data secure. Patient privacy is a big issue for telemedicine and why it's really getting prevented from taking off. I think COVID-19, as horrible as it is, I think it's really pushing telemedicine into the next century. I mean, it just pushes probably 20 years faster ahead than we would have been without COVID-19. Jurisdiction depends on the patient's location, not the doctors. So doctors must be licensed in the state. They can't just do telemedicine in a state they're not licensed in. Obviously, it's expensive to get licensed in multiple states, but laws could change to allow that. States could accept licensing from other states. So excessive legislation. We've got to get to the point where technology can be used to reduce costs. Right now, technology in healthcare is being used to increase costs. You've heard this story about Amazon, what they're trying to do to sell prescriptions. Also coming together with Chase Bank and Berkshire Hathaway, some others. These big employers are trying to address the problem outside of the system. So last year, the vast majority of prescriptions were picked up in person, but Amazon can simplify it by filling out prescriptions at the same time as offering cheaper prices. And they're part of this three-way joint venture. I don't know how that's going. It'll be interesting to see. The former student from this class who's in this business, who consults on healthcare, he was very unimpressed by it. He didn't think it was really working as well. But it's interesting to see. Here's this Gawande guy again. He has a venture that will target excessive administrative costs, high prices, and improper medical care. It will initially be aimed at the three firms. So these three firms have 1.2 million Americans as employees. So again, process improvements using tech to solve the problem. Another technological, here you get to see the three companies. A fundamental problem in today's system is that patients lack knowledge and control. Access to data can bestow both. Yet radical change demands a shift of emphasis from providers to patients, from doctors to data, better diagnosis. Apps are vying to see if they can diagnose everything from skin cancer to concussion. I've seen the concussion ones. It's interesting, some of the things they're doing on the sideline of football games. Management of complex diseases, diabetes apps, a video game designed to simulate the brain for Parkinson or hyperactivity disorder. There's some one of our students, a former student who was in this class, he actually has an app that he's building. He's getting in. He's a venture capitalist type, and he has an application he thought was really great. He came in second place in a competition in this thing of using this app to help people who have vertigo, get dizzy, have other types. They may be able to use this for people with dementia. It's interesting what technology is finding. So not only does it make us healthier, but it's cheaper. So it improves the efficiency. With data at their fingertips, common standards to enable sharing, and a strong incentive to get things right, patients are more likely to spot errors. Generation and aggregation of their data. Artificial intelligence is already being trained to unit of alphabet to identify cancerous tissues and retinal damage. There's some interesting things, and we'll see a couple of these, how well artificial intelligence is actually doing. But tech is starting to have a huge impact. And I think what's interesting and what you might note is we're not seeing hospitals on this list. We're not seeing pharmaceutical companies. We're not seeing health insurance companies. We're seeing Apple and Google. We're seeing the firms that have a reputation for doing things very well, very efficiently, in a big way. And when they get into it, they don't do things small because they're huge companies. They don't need another $20 million revenue source. They need a $10 billion revenue source. So they're going to go big. So they even say, Apple, Amazon, Google. Apple has spent 3 years preparing its devices and software to process medical data. Millions of Americans direct digital control of their own health information for the first time. Alphabet, Google's parent, has launched a third healthcare firm, Cityblock Health. You might look up Cityblock Health. That might be something you could add to your paper to get that little extra. There's about 10% of the paper that is other, and you could bring that in. So as subsidiary, and so these are AI firms, artificial intelligence firms. They're using data to try to figure out what really works. Alphabet already claims to be able to use AI to predict possible deaths of hospitalized patients 2 days earlier than current methods. All 5 firms have secretive healthcare skunkworks, are hiring medical talent, are backing extended healthcare startups. More and more tech. Use their various platforms to create entirely new channels through which medical care can be delivered. Use the hospital's data to generate alerts that draw doctors' attentions. The stuff we've been seeing over and over again. The right kind of firms are getting into this. Another article on apps. The apps make it possible both to measure whether the patients are adhering to their treatment and to collect evidence on outcomes. Many apps will complete the treatment, will compete to treat the same disease, which should spark very rapid innovation, something very rare in this industry. Lower prices, it's just amazing stuff. Another article on artificial intelligence. Use machine learning to analyze scans of brains. These projects have a common aim, that is to get the right patient to the right doctor at the right time. There are skin cancer detective systems that can do better than most dermatologists. Humans are able to identify 86% of skin cancers. The computer found 95%. So, and it had fewer misdiagnoses. That's pretty incredible. That's one thing you'll see not just here, but on X-rays. You're seeing that AI is very, very competitive against trained professionals when it comes to reading X-rays. Their system looks useful for a second opinion, so maybe you still go to a doctor, but you have a second opinion, so it might reduce some of the errors that doctors made. It's able to grade women according to the risk of breast cancer and decide the best time for the next mammogram. Cardiologists looking at these scans are searching for signs of heart disease, but can miss them 20% of the time. That means patients will be sent home and may have a heart attack. AI can detect changes invisible to the eye and improve the accuracy. So it may be like having a whole extra doctor there. And the wonderful thing about AI is once you have AI, you have it in a software, the entire world becomes knowledgeable immediately. So just because one doctor figures something out in California, every doctor in the world doesn't now know that. But with the AI and these systems that talk to each other, once one AI learns it, the entire world learns it. It's an immediate better system. So AI can make medicine more specific, being able to draw distinctions that elude human observations. We'll see some quotes on some medication that's incredibly ineffective. And if we had more information on the human genome, we could actually decide, hey, this medication doesn't work in your particular case, rather than giving these medications and just hoping that you're the 1% of the time that medication actually helps. And may be able to grade cancers or instances of cardiac disease according to their risk, and distinguish those prostate cancers that will really kill versus those that no treatment is needed. And remember, the side effects of prostate cancer surgery are quite negative. All right, here's one. Boy, we're getting really close to the end. I love this article. This guy, I don't know how to say his name, but Dave, I'll just say his first name, Davey. He's in India. I mean, these are just amazing numbers. He has cut the price of artery-clearing coronary bypass surgery from $1,500 to $800. That's in India. The same procedure costs $106,000 in Ohio Cleveland Clinic. And Ohio Cleveland Clinic is one of the good guys. You'll see in the video, it's one of the ones that stands out as being more efficient and more effective than those in the rest of the country. The chain uses web-based computer software to run logistics rather than licensing or building expensive new systems. So you must say, well, but that's $800, but boy, your chances of dying are really high. Well, let's see how good of a job he does. Some come for treatment they cannot get at home. Others escape long waiting lists for public health care or high prices. Consumers are incentivized to travel, so medical tourism is definitely an issue. I have it under other low-cost methods. Where I volunteer in Costa Rica, they promote medical tourism. It's cheaper to get health care in Costa Rica than it is in the U.S. especially for certain treatments. So your incentivized average heart valve replacement is $35,000 in Germany, but it's half of that in Austria, with little or no drop in quality. So the quality is the same. A hip operation can be 12,000 pounds in Britain, 10,000 in Turkey, and 4,700 in Poland. Two newest online firms based in Berlin hope to improve matters. They allow patients to search for medical treatments from a large selection of providers, offering clear information about pricing and the quality and staff of services. Fewer American patients came than expected, partly because health insurers are not interested in sending people overseas yet. But definitely, if you can go from $106,000 down to a couple of $1,000s, you have an incentive to pay someone's travel costs. All right, so this guy Devi, it's his outcomes were very similar, very similar in quality to others. I didn't have it in this article, but it was in the article. I must have skipped that part when I copied it over. So same quality over here, the same thing, half the cost but the same quality. So all right, so we're almost to the end. We just have about 10 more pages here. So what we'll do in the next class is I'll finish up these last couple articles, and it's going to go pretty fast because there's a few of them I don't cover very much of at all. So we're probably only 3 or 4 pages left. Then I want to do the porters. One of these articles has a website I want to show you. I think it's really exciting, and it's still up and running, that you might find interesting. Then we'll get into Porter's article. Specifically, we'll cover the last few well, before I get into Porter, we'll cover the last few notes from the class notes on this. There's a few quotes in there that I think are really interesting. Get into Porter, and then we'll probably have a Zoom session where we can talk about the videos, because I think they're really good. One thing I'll say about the videos before you get into them, and I'll let you know in the class email on the videos, is one student actually took all of his notes on the videos and he put them into a document. So if you want to have his document open while you're watching the videos, that might save you time taking your own notes. All right, so that's where we're going from here. We're almost to the end of this. I find this stuff incredibly interesting, so hopefully you're getting an idea, you're collecting notes and quotes, and you're ready to hit this. I'm not sure we've hit every single thing on this list, so before I do the very last video, I'll go through the rubric, and anything that I haven't hit on the rubric, I'll make sure to cover it.